Hi everyone, I'm Dr. Ed Martin. This training is the culmination of my work to develop the simplest, easiest, and most successful treatment planning technique available. I've talked to countless clinicians about treatment planning, and most of them, like me, find documentation unpleasant because it takes away time from direct work with patients. This technique should save you more time for that direct work with patients. I've known treatment from all sides. I've been a patient, I've been a clinician, and I've been an auditor. I have a PhD in counseling psychology and over 20 years experience at organizations that provide mental health and substance abuse services to adults and children. I've been a clinician working with adults and children, and I've been a quality management director auditing those patient records and training hundreds of clinicians on treatment planning techniques. I've also helped those organizations successfully get through audits by the Joint Commission, Medicaid, state licensing organizations like the Department of Mental Health Services, the Division of Addiction Services, the Department of Children and Families, and also healthcare organizations or health insurance companies. I'm confident this training will help you. So let's get started.
To begin, the key is simplicity for everyone concerned. Easy to understand, brief so it doesn't overwhelm anyone, doable now for confidence. You want your patient to feel confident. To keep this simple and save time, I offer you steps to follow so you don't forget to collect important items or struggle to remember them when you need them. Follow these 5 simple prep steps in order, and I guarantee you won't get stuck wasting time or stressing. Most of the information that you'll need for steps 1 through 5 can be found in the patient's initial biopsychosocial assessment. If you are the one conducting the assessment, you can save even more time by entering this information on both the assessment form and a blank treatment plan form at the same time. Step 1. Your patient's treatment plan starts with the diagnosis that you made on the initial biopsychosocial assessment. Keep in mind that when it comes time to writing up the treatment plan, you will need to pick no more than 2 main problems, the primary and secondary diagnoses, and their measurable symptoms. Why only 2 problems? Because focusing on any more than 2 problems comes with a number of significant risks. You risk overwhelming your patient. You risk no improvement since you've overwhelmed your patient with too many problems to address. You risk missing progress on all the problems. Lastly, you risk an auditor citation if you are not keeping track of things that you said were problems. I've seen this occur many times. Don't let it happen to you. Step 2. Pick the best 1 or 2 issues to work on immediately. I suggest problem 1 be the primary diagnosis and problem 2 be the secondary diagnosis. If you have more diagnoses, you have 2 choices. Group them with problems 1 or 2 if clinically appropriate, or defer them for later work. For this training, let's say you have a patient, Jane, and you both think that problem 1 is major depressive disorder, single episode, moderate. In the problem area of the treatment plan, write down problem number 1 from step 2. We're going to leave problem number 2 alone for now. Save time at intake by putting this information on both the assessment and the treatment plan form at the same time, or cut and paste it from one to the other. If you're not the one completing the assessment, look for this information on the assessment. It is usually in the diagnostic summary at the end or in the mental status assessment section. Step 3. Identify 3, but no more than 5 signs or symptoms for each problem. Why 3, but no more than 5? Well, first, most diagnoses in the Diagnostic and Statistical Manual of Mental Disorders, regardless of which edition, require no more than 3 signs or symptoms. Check it out and you'll see it's true. Second, don't you want to stay away from having too many things to address? So here's Jane's problem, and Jane has the following related symptoms: depressed mood, suicidal thoughts, and oversleeping. As you can see, we put the symptoms in the as evidenced by section. As I said before, save time at intake by putting this information on both the assessment and the treatment plan form at the same time. If you're not the one completing the assessment, look for this information on the assessment. It's usually in the diagnostic summary at the end or the mental status assessment section. Step 4. Work with your patient to give those symptoms numbers. In other words, make them measurable. We're aiming for frequency, how often, hourly, daily, weekly, etc., and/or severity, how much on a rating scale between good and bad. In Jane's case, let's say that she reports feeling depressed daily, that would be a frequency, and rates herself at a 7 on a scale of 0 to 10. 0 equals not depressed, 10 unbearable depression. Incidentally, 0 to 10 scales are also good ways of measuring anxiety, anger, and cravings. Just make 0 equal no symptom and 10 equal the worst imaginable. Thoughts of suicide 5 times daily, oversleeping 12 hours nightly. Some more on step 4. Why numbers? Well, because you can't measure success without them. Neither you, Jane, nor your friendly auditor Shirley from the Joint Commission will see any progress unless these numbers reduce or ideally go away. So this is the part of the video where people start to freak out because I'm mentioning numbers. They get glassy, they're like, I'm not good with numbers. But actually, everyone uses numbers, and this is fairly simple. Think about it. You're thinking about a movie. What kind of star rating did it get? Did it get 5 stars out of 5? Then it's good, right? How about the weather today? Is there a chance of rain? It's 0%. That's good, right? You use numbers every day, so you can do this. It's simple, it's easy, just stick with me. In the as evidenced by area of the treatment plan, write down all of the measurable signs and symptoms. If this is based on Jane's assessment at the beginning of treatment, this would be Jane's baseline symptom rates before treatment with you began. You and Jane will have succeeded if these rates reduce or go away, which is of course a rate of 0. This may seem obvious, but some don't get this. As you can see in the as evidenced by section, we now have made the symptoms measurable. Step 5. Collect a list of at least 3 but no more than 5 of the patient's strengths that will help her succeed in treatment. You will use this to complete the patient's strengths area of the treatment plan. Keep it to the necessary patient abilities for treatment to happen at all. Here is a list of some of the most basic ones. Arguably, all patients in talk-based treatment need to have the first 3 in order to benefit from it. If they don't have these, they might do better in some other service. Let's pick 4 for Jane. Now let's put those strengths in her strengths section. Now, believe it or not, that was the hard part. Picking the problems, picking the symptoms that go with those problems that you're going to address, and giving those symptoms numbers so you have a basis for change. The rest of it is the activities you've been trained to do to make those symptoms go down or away. You'll see. Okay, you've got all the prep work done. Now you're ready to write up the treatment plan. It'll only take 3 steps. Step 1. Complete the discharge goal area with the following statement. To be able to function without further need of, and here fill in your service type, either outpatient therapy, partial hospitalization, intensive outpatient services, etc. What? That's it? Nothing else? Yep. If you think about it, there are only 2 reasons why patients willingly leave your care. You think they don't need you anymore, meaning they either need a higher or a lower level of care, or they think they don't need you anymore. Either way, that's the end. Being solution focused means your goal is for your patients to no longer need you because their symptoms have gone away or reduced to a level that they can manage without need for your help. Remember, we're trying to be clinically sound but simple. This is both. So here's Jane's discharge goal. Step 2. Now for the short-term goals or objectives. The key, only one objective for each sign or symptom of a problem. Now you maybe can see why I tried to keep you to no more than 3 of them. I have seen treatment plans with 20 or more objectives. It's not needed, it's a liability. No one can accomplish 20 objectives while recovering from a mental illness or substance dependence. The patient's not going to feel any chance of success with that scenario. Here's the trick. Make each objective be either the measurable reduction or, if you're especially confident, the end of each sign or symptom that you listed. Short-term goals are results. When you attain these results, you've had success and you can stop working on them. Maybe an example would help here. So let's use an example of going to Hawaii. So there are objectives you must reach before you'll succeed. Objective number 1, buy an airline ticket. Once that's done, you can stop working on it and move on to the next thing, right? You're not going to keep buying more tickets. That wouldn't make any sense. Many clinicians treat objectives as activities, not results. For example, Jehoshaphat will comply with medication as prescribed, or Anastasia will attend family therapy twice a week. If you treat objectives as activities, you'll have long lists of them and you'll never be done. Okay, let me give you an example. So if your patient complies with medication as prescribed, do you want him to stop? Are you done when he complies? No, you're not done, right? Because you want to work with him to reduce symptoms. And he's got to comply with medication in order for those symptoms to reduce, right? As well as the other stuff that you're doing with him. An objective here is the reduction of symptoms, not complying with medication. An objective has to have a number that, when reached, tells you you've been successful and you can move on to something else. You can't move on to something else until those symptoms go away. Complying with medication is just an activity. So let's use Jane's baseline symptom rates to illustrate this point. As you know, they are feeling depressed daily, 7 out of 10, thoughts of suicide 5 times daily, and oversleeping 12 hours per night. So let's make the objectives be hopeful but clinically realistic reductions. Feeling depressed no more than 3 times weekly, a reduction from daily, at a 2 out of 10, a reduction from 7. Thoughts of suicide have ceased, 0 occurrence for 2 weeks duration, a reduction from 5 times daily, and sleeping no more than 9 hours per night, a reduction from 12 hours per night. For each of these, be sure to list the date on which you establish the objective. Usually that's the initial treatment plan due date. Later on, when your patient reaches the objective, fill in the date attained. But for now, leave it blank, of course. You're done with the objectives for problem number 1. Here's Jane's first objective and the date it was set. Step 3. For each objective, complete the interventions needed to address it, which is more than one in most cases. The key? The planned activities everyone who is working to help the patient, including the patient, and they should be geared toward treatment success. That usually means you, other staff, the patient, sometimes parents, sometimes others outside your organization with whom you will collaborate toward the recovery of the patient, For example, teachers, probation officers, primary care physicians, etc. All those clinicians who want to put patient activities in the objectives area, here is the real place to put them. Take medication as prescribed, or attend family therapy 2 times weekly are the planned activities for the patient toward reaching an objective. In addition to what the patient will do, there are the things that everyone else will do to attain the objective. For each, be sure to indicate the method and how often it should occur. Here are examples. The psychiatrist will provide medication counseling in individual sessions 1 time a week. The nurse will provide medication education in group sessions 1 time a week. The clinician will educate about A, the connection between thoughts, feelings, and behaviors, and B, effective coping skills to manage suicidal thoughts in individual sessions and therapy group sessions 1 time daily each. Jane's husband will call 911 if he suspects that Jane is suicidal as needed. Repeat treatment planning steps 2 and 3 if there is a second problem to address. Do these interventions sound familiar to you? They should, because they're what we've all been trained to do. We're not coming up with any new treatment techniques here. We're coming up with a way to document the treatment you usually do so that it lines up clearly for outcomes-based results. For Jane, here are some interventions we'll apply to address her first objective, reduction in her depressed mood. So we've added the interventions for Jane. Now you can see what everyone will be doing. You can set a target date when the objective will be reached. Don't forget to add the type of treatment or modality, who's going to be responsible for it, and how often it will occur. There you have it, a treatment plan that is easy to understand for your patient, for an auditor, and for you. Brief so it doesn't overwhelm anyone. Doable now for confidence. Everyone's confidence about getting improvement. Here she is in all her glory. Look, she's even smiling because she's so hopeful for success. Diagnosis-linked problems, measurable symptoms, treatment-oriented strengths, a measurable discharge goal, measurable objectives that are results, not activities, and activities in the intervention section where they belong. The end, really. But wait, you say, what about the other 2 objectives and the second problem and all its objectives? This treatment plan could be a lot of pages the way you're doing it. That's not brief. My answer, recycle. By brief, I mean that it shouldn't take you a long time to write no matter how many pages. On a computer, you can save treatment plans and therefore borrow previously written material via a copy and paste function. Here are 2 examples of recycled interventions that have been used time and time again. As long as they apply to your patient, there's no reason not to recycle.
I hope this training was helpful. With practice, it should reduce your stress, speed up your documentation, and make things easy to understand for your patient. It's also likely to please your supervisor and auditors. Best wishes.